Picture a dimly lit hospital ward. A physician reviews two patient charts. Both patients present with severe fatigue, pallor, and a lab result showing a classic microcytic anemia. On the surface, their presentations are identical. Yet, if that physician prescribes the same treatment to both, one will recover and the other will continue to deteriorate. Their underlying diseases are distinct, requiring completely opposite clinical interventions. Standard medical board preparation tries to solve this by handing you a table. You are expected to memorize columns of arrows, up, down, normal, to differentiate these lookalike cases. That approach is a liability. Under the pressure of a licensing exam or an active clinical ward, memorized arrows blur together. Relying on rote memorization creates fragile knowledge that breaks when you need it most. You can achieve true diagnostic intuition by isolating the primary pathophysiological divergence point between the two diseases. We are going to deconstruct two major clinical comparators, anemias and inflammatory bowel disease, to show you exactly how this works in practice. When you understand the biological driver, the lab results become a natural consequence. You eliminate the need for rote memorization because the underlying mechanism perfectly predicts the diagnosis. Let's start with our two anemic patients. One has iron deficiency anemia, the other has anemia of chronic disease. Both diseases restrict red blood cell production, resulting in the exact same microcytic hypochromic cells on a peripheral smear. To separate them, we have to track the iron. This diagram maps normal iron kinetics across three key locations: absorption in the gut enterocyte, storage in the macrophage, and utilization in the bone marrow. In iron deficiency anemia, the body experiences absolute iron loss. A chronic gastrointestinal bleed, for instance, physically drains the system. As a result, the macrophage storage completely empties to compensate. Without iron arriving, the bone marrow starves and halts red blood cell production. Anemia of chronic disease looks the same on a slide, but the starting point is entirely different. Here, the driver is systemic inflammation. That inflammation activates a specific complex, the IL-6 hepcidin axis. Inflammatory cytokines signal the liver to release a protein called hepcidin. The body assumes the inflammation might be an infection, and hepcidin's job is to sequester iron away so potential blood-borne pathogens cannot use it to replicate. Hepcidin achieves this by physically degrading ferroportin, the exit door on the macrophage. This permanently traps the iron inside the cell. The bone marrow starves and halts production exactly as it does in absolute iron deficiency. However, in this case, the iron remains within the body, sequestered in storage and biologically unreachable. Now deduce the lab work. Ferritin measures stored iron. In iron deficiency, the stores are empty, so ferritin drops. In chronic disease, the iron is trapped inside the macrophage, and ferritin spikes as an acute phase reactant. Next, look at total iron binding capacity, or TIBC. In absolute deficiency, the liver increases TIBC to catch any available iron. In chronic disease, the liver downregulates TIBC, specifically to keep iron out of the blood and away from pathogens. Understanding the hepcidin lock immediately explains the paradoxical high ferritin alongside a starved bone marrow. A similar logic applies to macrocytic anemias. Vitamin B12 and folate deficiencies both impair DNA synthesis, delaying cell division. This diagram illustrates the resulting peripheral blood smear. Because the cells keep growing while division is delayed, we see macroovulocytes with an elevated MCV and the pathognomonic hypersegmented neutrophil with 6 or more lobes. Under a microscope, they are indistinguishable. The critical divergence point occurs outside the blood entirely: severe neurological damage, which is exclusive to a vitamin B12 deficiency. Specifically, a lack of B12 causes subacute combined degeneration of the spinal cord. This cross-section of the spinal cord shows exactly where the damage occurs. Demyelination of these specific columns leads to a complete loss of joint position sense, sensory ataxia, and spastic paraparesis. This structural divergence creates one of the most critical rules in internal medicine. You must never initiate folate monotherapy without definitively ruling out a B12 deficiency first. If a patient lacks B12 and you administer only folate, you bypass the B12 blockade for DNA synthesis. The anemia rapidly clears, and the blood work returns to a normal state. But while you fix the lab numbers, the excess folate simultaneously accelerates the irreversible demyelination of the spinal cord. You've cured the lab results, but permanently paralyzed the patient. Identifying the neurological divergence point prevents a catastrophic medical error. In gastroenterology, we see this exact principle in inflammatory bowel disease. IBD is a spectrum divided into ulcerative colitis and Crohn's disease. This map of the GI tract shows their macroscopic anatomical distribution. Ulcerative colitis is strictly continuous, spreading proximally from the rectum. Crohn's disease, however, creates randomized skip lesions anywhere from the mouth to the anus. The more critical clinical differentiator is the depth of inflammation penetrating into the bowel wall. This cross-section shows the layers of the intestine. In ulcerative colitis, the disease is strictly confined to the inner mucosal and submucosal layers. Because the damage is on the surface, the mucosa develops intense friability. This leads directly to the classic presentation of bloody diarrhea and carries the acute risk of massive dilation, known as toxic megacolon. Crohn's disease behaves entirely differently. The inflammation here is transmural. It aggressively penetrates through every layer of the bowel wall. That transmural destruction ruins the structural integrity of the gut. It creates thick strictures, deep abscesses, and tunnels completely out of the bowel to form fistulae connecting into adjacent organs. This single variable of depth dictates surgical intervention. A proctocolectomy, the surgical removal of the colon and rectum, is curative for ulcerative colitis. Since the disease is superficial and confined exclusively to that location, removing the tissue removes the disease entirely. For Crohn's disease, surgery is almost never curative. Because the transmural skip lesions can develop anywhere along the entire GI tract, the disease simply recurs at the new surgical anastomosis sites. Surgery is reserved for managing physical complications, like an obstruction. Establishing the term transmural dictates the endoscopic findings, the life-threatening complications, and the surgical realities. We just replaced 3 dense textbook tables with 3 concrete physical mechanisms. The hepcidin lock dictates the entire paradoxical iron profile in the anemia of chronic disease. The neurological divergence of the spinal cord explains exactly why giving folate in isolation for a megaloblastic anemia is a catastrophic error. And the physical depth of transmural inflammation dictates the complications and surgical viability of Crohn's disease. Diagnostic tables are the end outputs of these biological realities. They should never be your starting point for learning. When faced with real patients or a complex board scenario, attempting to recall columns of arrows will fail you. Building an accurate foundational model of the disease is your only reliable diagnostic tool. The diagnostic markers you see in the lab are not random facts. They are the inevitable outcomes of the physical mechanisms occurring inside the patient.